All right, so we'll start off class with the respiratory system, but before we do, I want to say good morning to everybody. Everybody that's here, eager to get started, wants to say hello. All right, when you're taking notes, what I did is I pulled out information that you need to know as a respiratory therapist. So it's when you go through your anatomy and physiology lectures, it's all inclusive because they don't know what you're going to be specializing in. But respiratory-wise, there's certain things you need to know and certain things that really aren't that important. So I'm going to emphasize what you need to know when you're at the bedside. And starting off with the nose, I'll emphasize what's important with the nose. One of the things that you do with the nose is you pass a suction catheter through the nose and aim that suction catheter towards the trachea for people that can't cough and their lungs fill up with a lot of mucus. So when you're putting the catheter through the nose, sometimes you can't get through the nose and what's happening and what do I have to be careful of? So that's where the anatomy is geared. It's just having you understand the nose so when you pass that catheter, you know what you're experiencing. So starting off with the function of the nose, this slide, there's a lot of notes on it. So you can write tiny. I know some of you like to rewrite your notes after class. It helps you to remember everything. And it's a real good practice to do that. But to squeeze it all in, you're going to have to write tiny for this one. All right, so the function of the nose, there's three things. It filters out particles. The second one, it warms inspired air to body temperature. It warms inspired air to body temperature. It warms inspired air to body temperature. The third thing, it saturates the air with water vapor. It saturates the air with water vapor. Saturates the air with water vapor. So those three things. So how does it filter? Well, the way that it filters is you have your nasal hairs which capture particles. The other thing that happens is when air is going into your nose, it's got to turn the corner and go down. And when it does, particles will impact on the back of the nose, the nasal pharynx. Vanessa, there's a chair if you want to sit at the desk. Do you see it? So when the particles have to turn the corner, a lot of them will have velocity and they're going in one direction, and instead of turning the corner, they just impact against the back of the nose or the nasal pharynx. So that filters out particles. So you have the nasal hairs that trap particles, and then the fact that there's impaction in the nasal pharynx, and that filters out more particles. As far as warming inspired air to body temperature, inside the nose, there's a lot of capillaries that are real close to the surface of the nose, and the capillaries are always giving off water vapor or moisture. So when air passes through the nose, it's picking up that moisture. So by the time, we talked about that when I had you for the introductory class, how by the time the air reaches the trachea and the mainstem bronchi, it's fully saturated with water vapor and it's the same temperature as body temperature. So just passing through the nose and the oropharynx is going to warm and humidify the air. So it warms it and it saturates the air with water vapor. So those three things. One thing you notice, if you ever have a cold and your nose is real stuffy and you start breathing through your mouth, how dry your mouth gets, because your mouth isn't made to humidify and warm the air, so it dries your mouth out right away. Some people, I mentioned the suction catheter, when you're passing a suction catheter, some people develop polyps or growths in their nose, and when you're trying to pass a suction catheter, you can't, and it's because of that. The other thing that happens is there's a septum in the middle of the nose that's made out of cartilage, and in most people it's not straight. It curves either to the left or to the right. If you ever look inside of your nose and it looks like it's blocked, it could be that that center cartilage, I forgot the name of it, is curved in one direction or the other. and that's why a catheter won't pass. So if you ever try to put a catheter through the nose and it won't go, you just try the other side. And then if that doesn't go, now you're out of luck, but that's what you would do. All right, and then for the, anatomy of the nose. Does this follow your handout? Yes, it does. There's the word, the septum. I was looking for the center of the nose, that cartilage in the middle of the nose, the nasal septum. So you can write down that this cartilage commonly deviates to one side or the other. This cartilage deviates to one side or the other. Cartilage deviates to one side or the other. And then if you want to put a note like could cause a problem passing a suction catheter, just so you understand what the significance is. It could cause a problem passing the suction catheter. Right, on the side of the nose and the back of the nose, you can't really see it when you look in your nose, but back a little bit further, there's some bony protrusions into the nasal cavity, and it shows it on the picture. Two-dimensional, it's kind of hard to tell, but these are bony projections that kind of stick out into the nasal cavity, and their purpose is to make the air turbulent. And turbulence serves the purpose of filtering. It also serves to humidify and warm the air. So to write down some information on the turbinates, in your book they're called conchae, C-O-N-C-H-A-E. And then you can write that they project into the nasal passages. And they create turbulent flow.
For filtering, you said for filtering and something else.
Warming. Mm-hmm. Did you get all of that? It projects into the nasal passages, it creates turbulent flow. And this helps to humidify and warm the inspired air. Helps to humidify and warm the inspired air. And there's cells that begin in the back of the nose, in the nasopharynx. It begins again after the vocal cords. And the epithelium is got this fancy name, the pseudostratified ciliated columnar epithelium. You don't need to write any notes on that because we have another slide coming up and we'll talk about it. One more thing to tell you while I've got this picture out, not that you need to write notes on it, but just to mention what happens. Looking at a side view of the face, you can see the tongue, side view of the tongue. And a lot of people, when they fall asleep, the tongue falls backward and touches the back of the oropharynx, and it obstructs the airflow during sleep. So it's just relaxed, all these muscles relax during sleep, and that's why the tongue falls back, and it obstructs the upper airway, and you hear people snoring. Some people have such obstruction that their oxygenation actually falls when they're sleeping. They're good candidates for going to have a sleep study, and once that's documented, usually they end up being prescribed a mask to wear at night when they're sleeping. And the mask, it just blows positive pressure into the oropharynx, and that flow and that positive pressure kind of pushes the tongue away from the oropharynx and allows the airflow to be better when they're sleeping. So you deal with that a lot in respiratory therapy. There are sinuses, which are holes in the skull. So what do I need you to know about this? It would be nice to see the picture first. Okay. All right, so in the skull, there's these cavities or these spaces. There's some above the nose, surrounding the nose, behind the cheekbone, and our connection with these sinuses is usually when they get infected, and there's a lot of drainage from the sinuses. That's our connection. As far as memorizing the names of the sinuses, you don't need to do that. Just to know that they exist. I know with the neonates, a lot of times the tube that goes into their trachea, the endotube, is passed through their nose and into the trachea. And it becomes a problem because it plugs up their sinuses and the sinuses get infected, and before you know it, it's really thick yellow-green secretions coming out of it. So just to understand that the sinuses are there, I have a couple notes. They help with the production of sound. Does it mention that? Yeah, they help with the production of sound. So if you have a cold and your sinuses are plugged, you say, oh, I sound so nasal. And it's because the sinuses, instead of being open and helping with the production of sound, they're plugged up and then you sound nasal. It lightens the weight of the head. The sinuses drain into the area between the turbinates. So when there's a tube in there that stays in there, it ends up blocking the drainage of the sinuses. All right, so do you need to write any notes? That's good, right?
Mm-hmm.
All right, so the oral cavity, or the opening of the mouth, there's a few things we need to know about that. It is separated from the nasal cavity by a hard palate and a soft palate. It used to be that, and I don't think this is done anymore, it's not recommended to patients, but patients that snore, when they go in to have their sleep study done and then they talk to the pulmonologist afterward, one of the suggestions that the pulmonologist would make is, well, have the soft palate removed so that opens up your airway and then you won't snore at night. Well, people that have their soft palate removed, when they're eating food and they go to swallow, the food tends to go up into their nose. So that burns. Have you ever done that when you're laughing and you get something up in your nose? It burns terribly. So not a good surgery to have to avoid snoring. So the soft palate needs to stay there. The uvula. There's a projection of something that hangs down in the back of your throat. This shows it as a side view, but when you open your mouth really wide and look at the back of your tongue, you see something hanging down. And just like everything in our body, everything has a purpose. And the purpose of the uvula is to control the flow of food. It controls the flow of food. When removed, food gets into the nasal pharynx. Do you need to write that? When removed, food gets into the nasal pharynx. Next thing listed are the tonsils. The tonsils are on the side of the oral cavity. Oh, here's the picture that I want. Okay, so we see the uvula hanging down, and that's to control the flow of food. On the sides of the oral cavity are the tonsils. This is part of the lymph system, so that's lymph tissue. Sometimes kids have chronic infections of their tonsils, and the tonsils will be removed. When I was younger, it was believed that tonsils serve no purpose in the body, and that once you reach a certain age, tonsils should be removed. So I had no problem with my tonsils, but when I was 5, the doctor said, "Do you still have your tonsils?" And they scheduled me for surgery and removed my tonsils. Can you believe that? The body doesn't have extra parts to it. What naive thinking. So no. All of you probably still have your tonsils? You don't have yours, Fred? No. Were they infected a lot?
Yeah, mine
and had
were
to been removed? Yeah. So tonsils are part of the immune system, and you need them to fight infections. So you want them to stay there if you can help it. Did I get everything? No. So next is the tongue. In the back of the tongue is a gag reflex. The back of the tongue is the gag reflex. And when the gag reflex is stimulated, it causes you to laryngospasm or your stomach to spasm and want to throw up. It induces vomiting, I guess, when you hit the gag reflex. So patients that have airway obstruction, you can't just put something on the tongue to hold the tongue down, because when you put something in the back of the tongue, it hits that gag reflex, and they could vomit. The vomit could get into their lungs, and when stomach secretions are in the lungs, it does a lot of damage. There's a lot of acid in stomach secretions, and it causes a nasty pneumonitis in the lungs. So we try to avoid that at all costs. So putting something to hold the tongue in place is not a good idea. When a patient has to be unconscious, so yes, during a code, a comatose patient, we can put an airway in there to keep the tongue out from the back of the throat. But if they're any part awake, then no, it's not a good idea. You had a question?
Do you guys treat patients differently if they have if they're tongue-tied?
What is tongue-tied?
When you I have it, so I can show you when you can't lift your tongue all the way up. I don't know how you it's like a string or it's like a piece of muscle. I guess when you're born you can't usually they cut it, but they didn't do that to me. So what the doctor told me is you can't. Sometimes that doesn't happen to you. Your tongue doesn't get in the way because you're tongue-tied. So I was wondering if that has anything to do with, or you treat patients differently because of that.
I've never come across it. So with you have less risk of your tongue falling back.
Right.
Because of that extra ligament holding it.
Right.
Wow. So that's a good thing. I guess we all want to have.
No, you don't. You can't I don't know if anyone's Spanish, but you can't pronounce the double R, or you can't stick your tongue all the way out. I mean, it's not a bad thing, but it's just little things like that.
So to help with speech, it's better to have that tongue movement.
Right.
Exactly. I understand. Very interesting. Yeah. So maybe tongue-tied is that the right word to use to describe it?
I Googled it, that's what I said, but I'm not sure.
Oh, really? I have a sentence for you to write. Do you have room at the bottom of the page? Comatose patients lose the irritant receptor response and can aspirate foreign material into the lungs. So I'll read it slowly so you can write it. Comatose patients lose the irritant receptor response and aspirate foreign material into the lungs. I'll read it again. Comatose patients lose the irritant receptor response and aspirate foreign material into the lungs. So one thing we say is they've lost their airway protection when they're comatose. And patients that are, I don't know, they code. You know, the heart stops, we do CPR, and we get them back. And within 24 to 48 hours, they develop pneumonia. Well, why would they develop pneumonia? They didn't have pneumonia when they had a heart attack. But what happens is when they're unconscious, they lose that irritant receptor response, and saliva, any bacteria in the oropharynx will go into the lungs and they won't cough. And it just sits there. And then within 24 to 48 hours, a pneumonia starts. So comatose patients, we try to protect their airway, usually with an endotube, putting an endotube in. All right, the pharynx is actually the space that's behind the nose and the mouth and below the base of the tongue. So the pharynx is a space. It extends from the nasal cavities and mouth to the point where the airway and the digestive tract separate. So there's 3 sections. The nasopharynx, you can write down, this is behind the nasal cavities. The oropharynx is behind the tongue, but I have something more specific. It says from the uvula to the epiglottis. From the uvula to the epiglottis. And then the hypopharynx, and I think in your textbook it calls it the laryngopharynx. It's between the epiglottis and the larynx.
Between the upper...
between the epiglottis and the larynx. Larynx. Okay, and then the next thing mentioned is the eustachian tube. This connects the middle ear and drains into the nasopharynx. So it connects the middle ear and drains into the nasopharynx. See if we can find it here. We're looking for the eustachian tube in this picture. So it's going to drain into the nasopharynx. Okay, on the top right, it says eustachian tube and it points to this area. So there's a tube that goes up into the middle ear. And in children, it's so narrow and it gets plugged up a lot. Any little bit of inflammation plugs it up. They become really susceptible to middle ear infections when they're little. The other thing that happens is on an airplane traveling. You ever notice that infants cry a lot when you're descending? And it's because the pressure in the middle ear can't equilibrate. So as you're descending from high altitude down to low altitude and the pressure increases from the middle ear, it's just, the pressure is stuck in there and it's just expanding it and it's painful. And they can't equilibrate. For us, all we do is swallow a couple times and the pressure equilibrates and we don't even notice it. But infants, that eustachian tube, sometimes it's inflamed or plugged, and then the middle ear develops inflammation and swelling also. Okay, we covered all of that. If we put we pass a tube through the mouth and we want it to go into the trachea and we miss the trachea, where does the tube end up? In the esophagus. Why would that be a problem if we're trying to put a tube into the lungs and instead it goes into the esophagus? air only goes into the stomach, and now we're not ventilating the person and giving them oxygen. Good. All right, so the next structure is the larynx. And the larynx is this big box that's not the shape of a box at all, but it sits on top of the trachea. Its purpose is to protect the lower airway. Once you get below the vocal cords, the lungs maintain a sterile environment. So they're in a normal healthy lung, there's no bacteria, no virus in the lungs. And of course that has to do with all the mechanisms that are in place to keep the lungs sterile. One of the mechanisms is the larynx and the purpose that it serves. The other part of the larynx is that it contains the vocal cords, and we need that to produce sound. Do I have some more notes for you? Yes, for the structure. So when you use a laryngoscope, you lift up the tongue, get the tongue out of the way, and you're able to see the larynx from looking down through the mouth. You can see the larynx. And this is the view that you see when you look down. So you see the base of the tongue. So if you pull the tongue out of the way and look down, this is what the opening to the larynx looks like. One thing that doesn't show up, well, all right, it's pointing to the epiglottis, but what you can't tell from this view is the epiglottis is a flap that actually goes over the larynx when we swallow, and then it lifts back up again so that we can breathe. So it's a flap that goes down and up. This is not a good picture of the epiglottis. Did it show up on any of the other ones? This is probably gives you a better idea of what the epiglottis looks like. So after the base of the tongue, there's a flap, and when you swallow, the flap will come down and cover the larynx so that food gets diverted over to the esophagus. All right, so what do you need to write for epiglottis? It's a flat cartilage, begins at the base of the tongue, it diverts food away from the trachea. All right, so you want to write small and I'll repeat it? All right, so flat cartilage. Begins at the base of the tongue. It diverts food away from the trachea. Diverts food away from the trachea. Everybody's got that? Yes, I used to think that when you swallow, there's this flap that seals off the airway so that no food gets in there. And it doesn't seal at all. It diverts food away from it, but it doesn't form a seal. So when it comes down, there's no seal formed on the larynx. It just comes down and food gets diverted away from the airway. So that's why sometimes we can still aspirate if we're talking and swallowing at the same time. So there's no seal there. What is the Vallecula? That's an interesting word. You're going to hear that word a lot when you learn intubation in your equipment lab, in equipment class. And when you're trying to visualize the vocal cords, so you know where to put the endotracheal tube, you have to put the larynx in a little spot. And I'm just really not liking this picture. I have to go back. All right, so when you put the larynx on the tongue and you move the tongue out of the way, you're going to put the tip of the laryngoscope blade. The blade doesn't have any sharp edges, by the way. You're going to put it right here in this area. So the base of the tongue, right before the epiglottis, and that little area is called the Vallecula. So it's a real fancy word for a little space. So what is the Vallecula? Do I have some words for you to write it down? No, so we have to come up with our own words. How about space between the tongue and the epiglottis? Insert laryngoscope blade here to lift the tongue. How's that? Insert the laryngoscope. Can you spell laryngoscope? Insert the laryngoscope blade here, meaning the vallecula, to lift the tongue out of the way. You got that? All right, you guys are good note takers. Next you have the vocal cords. And the vocal cords, this is a good picture for the vocal cords. The vocal cords here show up as white with pink mucosa around it so you can see them really well. We know the vocal cords move in and out to produce sound. Right before you cough, your vocal cords close and your abdominal muscles tighten and you build up a lot of pressure in your lungs. And then when the vocal cords open, air leaves your lungs forcefully. So if you're trying to cough something out of your lungs, that's the mechanism for coughing. Is you take a deep breath, your vocal cords shut down, or close actually, they don't shut down, they just close. So pressure can build up in your lungs, and then when the vocal cords open, air will blast out more forcefully. All right, what have you got next? Let's see. So the true cords are a ligament. So it's a real sturdy material. It's a ligament. The true cords will be resting against the endotracheal tube when it's in. So sometimes it can swell. And after you take the tube out, patients can't talk very well. They sound very hoarse. And it's because those true cords were resting against the endotube. I don't think you have to write that. The false cords are above the true cords, helps to close off the airway when generating pressure to cough. All right, so you can write that down. I'll read it to you. The false cords are above the true cords. Helps to close off the airway. Helps to close off the airway. When generating pressure to cough. And the glottis is just the opening between the cords. The glottis is the opening between the cords. You should see some pictures here. There's no sound. All right, I guess no sound. All right, so we're seeing a picture of somebody's vocal cords. Let me back it up a little bit. This is the base of the tongue. So if you're looking down inside at the airway, the base of the tongue, actually we're looking at the epiglottis. Base of the tongue would be back a little bit further. And then the opening, just this area, is called the glottis. So when you're intubating, this is what you want to see before you pass the tube into the trachea. So you don't just move the tongue out and push the tube in. This is the view that you're looking for when you're intubating. So you never, never, never pass a tube unless you're seeing this with your eyes, and then you pass the tube. I think it goes through the movement. Oh, look at all the swelling that you see. It's kind of enlarged and inflamed. And I don't know Spanish, so I have no idea what this is saying. Can anybody interpret for us?
That says polyp of the vocal cord.
Oh, okay. So this growth right here must be the polyp?
Yes.
All right. Somebody like that is going to have a hard time with speech. Okay, what is this?
Cyst. Yeah.
A cyst on the vocal cords? So I guess granuloma interprets exactly like that?
Yes.
I guess we see it though. Look at that. Wow. That could cause somebody to be short of breath when they try to breathe fast.
That's
Is this paralysis?
Yeah.
Okay.
Of the vocal cord.
So one cord isn't moving? I wonder if it's this one because it's all floppy. This one seems to have some tone to it and this one's all floppy. Edema is edema, right?
Yes.
All right, so you can see the swelling.
Reflex.
Oh, from reflux. So somebody has a lot of regurgitation from their stomach, and that regurgitation is causing irritation of the larynx. Laryngitis. So, this is somebody who's really hoarse when they're talking. That's what? Bronchi? What's bronchi?
I guess it's a type of edema or something.
Oh, question?
Does the tube go through the vocal cords, like into there?
Mm-hmm. Yeah, so there's a cuff on the end of the endotube, and you have to push the tube down far enough so that cuff, that part that inflates, is past the vocal cords. So once you see that cuff go past the vocal cords, that's when you stop. And then you know the tube's in the right spot. Oh, somebody's got a tumor of the, what is this? Oh. Can you tell where the tumor is? It's a little bit blurry.
Yeah, it's those little balls up there.
These?
Yeah.
Wow. It's a great picture of the epiglottis, though. I know that's not what they're showing, but check out the epiglottis. You finally get to see it. Okay, good enough. All right, we'll talk about the larynx and then we'll take a break. The thyroid cartilage. In lay terms, we refer to it as the Adam's apple because that's what protrudes. Males have more predominant larynx, or thyroid cartilage compared to female. And purpose of the thyroid cartilage, is to protect the vocal cords and protect the upper airway. I guess protected is very general because having the vocal cords there and all the supporting structures attached to the larynx, that's how it's protecting the airway, just by supporting these structures. So protecting, it's kind of like a roundabout way. So picture the thyroid cartilage, and when you look at it from the back, you see how it doesn't go all the way around. There's another cartilage listed next. It's the cricoid cartilage. It's below the thyroid cartilage. This cartilage. It's the only complete ring of cartilage in the larynx or trachea. Ooh, that would be a good test question, wouldn't it? Mm-hmm. What is the only complete ring of cartilage in the larynx or trachea? And your answer would be the cricoid cartilage. So it's the only complete ring of cartilage in the larynx or trachea. So when we're placing an endotracheal tube, the cricoid cartilage is pretty much the narrowest part of the larynx, so it kind of limits how big of a tube we can use. The other thing to note about the cricoid cartilage, and it's the narrowest part of the airway for infants also. It's the narrowest part of the airway in infants. I'm not going to give you more information on that for now. When you have the neonatal class, we'll discuss it in more detail. But just real quick, you don't have to write it down. When intubating an infant, the tube that we use does not have a cuff on it. Well, how can we deliver positive pressure to the lungs if we're not sealing off the airway by using a cuff? And the answer is that the cricoid cartilage is so narrow and it fits kind of snug around your endotube. So you don't need a cuff in order to maintain pressure in the lungs. So that's what's coming up. Next you have the cricothyroid ligament. The cricothyroid ligament is between the thyroid cartilage and the cricoid cartilage. This is used for emergency opening of the airway. Should I repeat that? It's between the thyroid cartilage and the cricoid cartilage. Used for emergency opening of the airway. So this is not done in the hospital, but you'll hear paramedics doing it out in the field. If somebody aspirates something and it gets stuck in the larynx and they can't get a tube through, they can't ventilate, what they carry with them is it's like a really large bore needle that's really sharp, and they'll penetrate the ligament, the cricothyroid ligament, and hook that up to an adapter in the ambu bag, and then they'll start ventilating below the vocal cords. A large piece of meat, a muffin, it can get stuck in the larynx and be unable to clear it in order for the person to breathe. So if they have to open up the airway in an emergency situation, that's what they'll do, is they'll place a large bore, it almost looks like not a knife or a dagger, but it's just something thick and sharp, and it penetrates that membrane, and then they attach that small tube to the ambu bag and start bagging. Next thing you have is the hyoid bone. Can you look at the picture and tell the purpose of the hyoid bone? Yes. So it supports the larynx. It's a supporting structure. It supports the larynx. don't see arytenoid cartilage in any of the pictures. But the purpose of it, of the arytenoid cartilage, is to move the vocal cords open and closed. The arytenoid cartilage moves the vocal cords open and closed. All right, we'll get started with some more notes. Between this slide and the next slide, I want you to write down that below the larynx begins the lower respiratory tract. I'll read it again so you can write it. Below the larynx begins the lower respiratory tract. And write this down. The lower respiratory tract is sterile. The lower respiratory tract is sterile. Okay, and then we'll start notes about the trachea. So this begins the conducting airways of the lungs. The trachea begins the conducting airways of the lungs. And the name of conducting airways. What we need to do is get air from the atmosphere down to the alveoli so that gas exchange can occur with the blood. So in order to get air down, air travels through the conducting airways to get to the alveoli. So that's what we'll discuss now. So in the trachea, the size is 10 to 12 centimeters long, and it's about 2.5 centimeters in diameter, just to give you an idea of the size of the trachea. So 2.5 centimeters in diameter. And the trachea isn't rigid. I mean, it can enlarge and get smaller, so it does move a little bit. There are cartilaginous C-shaped rings, about 16 to 20 of these cartilaginous rings. I think the handout that I gave you in the spring was better than this one. These rings, these cartilaginous rings don't go all the way around. Do you remember why?
So it can expand.
The sound goes down.
Yeah, the esophagus is behind the trachea, and you can have cartilage touching the esophagus because food would get stuck on the way down. So there's no cartilage on the back of the trachea, just a smooth surface because it's shared with the esophagus. The trachea ends at the carina, and the carina is the point at which the trachea divides into the left and right mainstem bronchi. So we talk about the carina a lot. We say, okay, when you pass the suction catheter, push it down until you hit the carina. So you think the carina is this landing area, but it's not. It's just a bifurcation where the left and right mainstem bronchus branch off from the trachea. Now, one thing to note is the angle of the right and left mainstem bronchi. They're not the same. So do you remember making your lung model? And you had an angle of the mainstem bronchi a certain way? The right mainstem bronchus was more direct with the trachea, but the left mainstem bronchus had a greater angle because the heart is here, so it has to angle past the heart to get to branching off into the different lobes. Why do we care about the branching of the mainstem bronchi? Do you know any application to why this is important?
If you start too far, or if you put in too fast, this may go to the right lung because of the angle.
Very good. So in passing the endotracheal tube, if we push it down too far, Usually ends up in the right mainstem bronchus, and that's because of the angle. It's more directly in line with the trachea. But what about infants? If we push the tube down too far in an infant, what do you think happens in the infant? Will the tube slide into the right mainstem bronchus most of the time with infants? Yeah, it's evenly split. Very good. Because of the angles. If you go down too far, it has just as much of a chance of going into the right mainstem bronchus as the left mainstem bronchus. So the tube can go down in either way. But with adults, it just kind of follows this pathway. It goes into the right mainstem bronchus. And then looking at a chest x-ray, from your seat, I don't know if there's too much light. Where there's air, you see black, and where there's tissue or fluid, you see white. And with the trachea, with the trachea, can you see it here from where you're sitting? You can? And you follow it down. Can you tell where it's branching into the right and left mainstem bronchus? You can see it? All right, so this is what you learn to do on your patients at the hospital. In the morning you pull up the x-ray and you want to find where the carina is, and then you look for where the end of the endotube is. And this does not have an endotube in the trachea, so you don't see the endotube. But you want to make sure that it's far enough above the carina so that when air goes through the tube, it ventilates both lungs. So that becomes one of your responsibilities. And the clinic instructors go through this a lot with you. So every day you're looking at x-rays, you become very good at it. All right, and then the airways divide from the mainstem bronchi into lobar bronchi. So we have, on the right side, we have 3 lobes. The right upper lobe, the right middle lobe, and the right lower lobe. In the left lung, there's 3 lobes, but it's named differently because of the way it branches. So we say we have a left upper lobe. Instead of saying left middle lobe, we call it left upper lobe lingular segment, and then the left lower lobe. So why does it have that name? This picture will work. Excuse me. Looking at this picture, on the right side, again, when you're looking at a picture, it's opposite your body, so the left is the right and the right is the left. So looking on the right, you see right upper lobe, right middle lobe, and then all this consists of the right lower lobe. On the left side, it looks like there's just 2 branchings, one here and one down here. So the left upper lobe and the left lower lobe, but instead of saying left middle lobe, we call this the left upper lobe lingular segment. So it's the equivalent to a left middle lobe. There's one more thing I want to point out about this picture. And when you're listening to breath sounds and you want to listen to the lower lobes, what's amazing is the lower lobes of the lung occupy most of the back. Other than the upper lobe, which is above the scapula, you're listening to the upper lobes, the rest of a patient's back is the lower lobes. This posterior view shows that, where you've got the lower lobes occupying most of the back. And then the upper lobes, of course, are above the scapula. So what if you were to listen to the right upper lobe? Where do you think you would listen? Anteriorly? Okay.
Anteriorly.
Where else? Mid-clavicular? Okay. Anything in the back for the right upper lobe?
scapula?
Yeah, above the scapula and the back. So that's right upper lobe. What if you're going to listen to the right middle lobe? Let's see if the picture helps us with that. So looking on the side of the person's body, do you see the middle lobe a little bit on the side? So you could listen laterally to the middle lobe. And I think that's all my questions. There's a test question, like where would you place your stethoscope if you're listening to, and then it gives you a lobe, and you have to figure out where to listen. Think you'll be okay with it? Mm-hmm. Upper lobes, so left upper lobe, anteriorly and posteriorly. Left lower lobe, you're going to listen posteriorly. And middle lobes, laterally. What are the fissures of the lungs? They're a separation on the surface of the lung that divides the lung into parts. I'll read it slowly so you can write it. Separation on the surface of the lung. Separation on the surface of the lung divides the lung into parts. So the right lung has, do you need me to repeat that again? No. So the right lung has 2 fissures and the left lung has 1 fissure. So the right lung has a fissure that separates the right middle lobe and the right lower lobe. And then it's called the oblique. And it tells you what oblique means. It means like a slanting fissure. So instead of something being horizontal or being vertical, it comes at a slant, and because of that slant, it's got the name oblique. So it's between the right middle lobe and the right lower lobe, and there's one on the left, same thing. Nope, it's not the same, is it? All right, so the commonality is the lower lobe has the oblique fissure. This one separates right middle lobe and right lower lobe. This one separates left upper lobe and left lower lobe. The right lung has a horizontal fissure, so you can tell which direction that one goes in, and that's between the right upper lobe and the right middle lobe. And let's look at a picture and see if we can find the fissures. We don't have a picture?
The anterior view there has it, I think. Top left.
Okay. So between the right upper lobe and the right middle lobe, there's a division of the tissue. Which fissure is that?
Horizontal?
Very good. That's the horizontal fissure. And then looking laterally, you can see this slanting fissure, or this oblique fissure. On the right, do you see the same thing on the left?
Yes.
Yeah. You see the slanting fissure? Which lobes is it between?
Left upper and left lower.
Very good. So between the left upper lobe and the left lower lobe, you have the oblique fissure. All right, so bedside application would be when you're looking at an x-ray. Sometimes fluid gets in there and you wonder what that line of fluid is in the lungs, and you'll be able to identify it as having fluid in the fissures. So that's the application to that. Bronchi, it says name the 5 divisions of the bronchi. Do you know what the first division is coming off the trachea?
Main stem.
Okay, so the main stem bronchi is first.
Lobar.
Very good. Next is lobar bronchi.
Segmental.
Segmental.
And small.
How do you know that so quickly?
Listen to your tape. Yeah.
All right, so did you write down your main stem bronchi and the lobar bronchi? And then after the lobar bronchi comes segmental bronchi. And then the segmental bronchi branch again to form subsegmental bronchi. And then because they couldn't think of any other names after that, they call it the small bronchi. So would you consider the bronchi part of the conducting airways?
Yes.
Yes. Okay, the other thing to note is that bronchi have complete rings of cartilage. And that's it for cartilage, because after that, we go into the bronchioles and there's no cartilage. All right, so it shows you a picture and wants you to locate the bronchi. Let's start on the right. What do you think this is called? Right main stem? What is this called?
Lobar.
A lobar bronchi. And then that branches. And what do you think this is called?
So,
Segmental? Yeah, remember you had to do the segments in your lung model? And you had to point one straight up for the apical segment? You had one coming anterior, which it's kind of hard to see anterior on a two-dimensional picture. And then one went towards the back. So those are the segmental. And what would you call this if it branches off of a segment? Subsegmental. Okay, good. All right, good job. All right, next is the bronchioles. You can write that they have no cartilage. They're 1 to 2 millimeters in diameter. And write this down. They have 20 times more cross-sectional area than the trachea. I'll read it again. 20 times more cross-sectional area than the trachea. All right, so we said the trachea is 2.5 centimeters in diameter, and we're saying that the bronchioles are 1 millimeter in diameter. So how can they have more cross-sectional area if they're so tiny? Yeah, because there's so many of them. And this is what helps with decreasing airway resistance. When you pull a lot of air into little tiny bronchioles, you would expect it hard for the air to get through. But because there's so many and the air is dispersed to so many bronchioles, there's very little resistance to flow when air is trying to get down to the alveoli. So the bronchioles branch about 13 times. They keep getting smaller until they end at the terminal bronchioles. All right, so for this slide, for transitional and respiratory zones, a respiratory zone is where air exchange takes place with the blood. The respiratory zone means that air exchange takes place with the blood. So respiration is considered taking in oxygen, getting rid of carbon dioxide. So the air exchange takes place with the blood. And the terminal bronchioles are the last of the conducting airways. Terminal bronchioles, last of the conducting airways. You had this slide in the spring. I remember telling you the last 3 bullets. Put a bracket around it. The respiratory bronchioles, the alveolar ducts, the alveoli. All of this makes up the sinus. A sinus is A-C-I-N-U-S, a sinus. The sinus is another word for the respiratory zone. So the respiratory bronchioles have pouches of alveoli on them. For alveolar ducts, you can write that there's about 16 alveoli attached. For the alveolar ducts, 16 alveoli attached. Okay, and then lots of notes on the alveoli. It's the final anatomical unit. The final anatomical unit, meaning it doesn't divide any smaller than that. You know, you've reached where you have gas exchange taking place. So, final anatomical unit. It's the primary site of gas exchange. It's the primary site of gas exchange. Write down that there's about 400 million alveoli in an adult lung. I'm telling you 400 million. And that's going to be arbitrary. So if you're reading, because I had 300 million written, I crossed it off, I wrote 480 million, I crossed that off. So I think as you're reading, you come across these different estimates of how many alveoli we have. So you know that's not going to be a test question. So yeah, around 400 million. I'm making my own estimate. The surface area of the alveoli is equal to the size of a tennis court. So when you say it's equal to the size of a tennis court, that kind of gives you an idea of how much surface area there is for blood to pick up oxygen and get rid of carbon dioxide. And then write down that each alveolar membrane is surrounded by an extensive capillary network. Each alveolar membrane, or each alveolus, is surrounded by an extensive capillary network. All right, so I need you to identify all those structures in this picture. All right, so we have a bronchiole, and all these grape-looking things are alveoli. So which bronchiole would this be? If it has alveolar ducts attached to it, it's got some alveoli attached to it, would you call that a terminal bronchiole or a respiratory bronchiole? Respiratory. Very good. It's a respiratory bronchiole because now gas exchange is taking place in this area. What is this little canal that leads to all these alveoli? Okay, alveolar duct. And what are all these balls considered? Alveoli. Did I miss something? The sac, the alveolar sacs? Okay. And then the capillaries. Why are there green capillaries? I wonder if that's the lymphatic system. So you see blue for, it's probably carrying blood that has very little oxygen in it, so they colored it blue. And then once the oxygen was picked up, then they colored the capillary red, because now it's going to travel back to the heart. But the green, I'm imagining, that must be the lymph system that takes fluid away from this area. All right, good job. Okay, and then some more notes on this one. Do you remember this, hearing it again? Does it come back to you because you had it in the spring? No, is it good to have a repeat?
Yes.
All right, because I was thinking, why should I tell you again? I already went through this, but sometimes repetition is good. It refreshes your mind and helps you to remember the material better. Okay. So for type 1 cells, write down that these are the epithelial cells. Epithelial cells that form the alveolar membrane, that form the alveolar membrane, where gas exchange occurs. Sorry, the epithelial cell is very, very thin. It's a half a micron thick. And when it's really, really thin, it helps for oxygen and carbon dioxide diffusion. All right, for the type 2 cells, these produce surfactant. And surfactant is a fluid that lines the alveoli and prevents the alveoli from collapsing. So it's a fluid that lines the alveoli and prevents the alveoli from collapsing. And so another, some catch-all words to use, it decreases surface tension. Decreases surface tension. So you'll hear those terms used like in infants that are born prematurely. They don't have surfactants being produced in their alveoli. So there's high surface tension in the alveoli and they like to collapse. And so now we can give exogenous surfactant. You know, it's produced in a lab or it's taken from cows or sheep lungs and ground up and injected into the airways. And it'll find itself in the alveoli and then the alveoli will stay open. So we talk about surface tension with delivering surfactant. We talk about surface tension when patients are when they have shock lung or ARDS. The lungs get really stiff after a trauma or a massive infection in the body. The lungs get really stiff and they lose surfactant in the alveoli. So you'll hear surface tension used. But it's basically the alveoli wanting to collapse. There's high surface tension and the alveoli want to collapse. 1 to 2. And then the picture where you see nothing is where air is in the alveolus. You see the alveolar membrane, that epithelial cell, type 1 cell. And then within that cell, you see another cell. You see the type 2 cells, and they produce the surfactant, and then they secrete the surfactant, and that coats the membrane and keeps the alveolus open. Do you know what the red blobs are? Yeah, red blood cells coming through the capillary. Good. Does this make sense? Normal alveoli that have surfactant stay open, but without surfactant they tend to collapse because of the high surface tension. Pores of comb. Do you remember what those are?
Connect alveoli to the other alveoli.
Yeah, they're openings that connect one alveolus to the other. And what purpose do they serve?
Reducing.
So if one's plugged, you go to the next air.
Yeah, so it helps with cross ventilation. Keeping the windows and the doors open, you get better ventilation. So the pores of cone help air to move to alveoli that aren't getting a good air supply. Yeah, I just have written openings between alveoli. So you can write down what you want for that. Canals of Lambert are between the terminal bronchioles. It's a connection between terminal bronchioles. And it's to improve air. Or to improve ventilation. Can you see this dark arrow right here, and it's pointing to a hole in the alveoli? Mm-hmm. And those are called the pores of cone. All right, alveolar macrophages are cells that hang out in the alveoli. They devour bacteria and other material invading the alveoli. I'll read it again. They devour bacteria and other material invading the alveoli. They're part of the immune system. So devouring bacteria, the way to do it is the macrophage will surround a bacterium and then just digest the bacterium. And it'll use powerful enzymes within the macrophage to destroy the bacteria. So same thing with cigarette smoke, breathing cigarette smoke into the lungs, and the toxins that get into the alveoli are devoured by the macrophages. And then all these toxins stay in the macrophage, and then if the macrophage dies, it releases the toxins. So that's what happens from cigarette smoke, and all the toxins that get in there is the body tries to clear it, but it ends up killing the macrophage, and then all these enzymes get released and start destroying the alveoli, and then you end up with the chronic lung disease. How do you guys feel about the campus becoming tobacco-free? It's easier to breathe around here. And then smokers have to go somewhere. I wonder where they go to smoke.
In their car.
In their car with the windows up.
With their windows up, really?
Yeah.
To really get rid of them.
You can't have it. Can't have
I
it
think another
kicking into
reason why
them.
they did it.
You can't what?
They can't have the kicking into
No.
Another reason why I did it too was, I went to a college before, they spent $300,000 a year cleaning up cigarette butts.
Oh, no kidding.
And it says, we could use that money for something else.
Yes, another $300,000 richer.
Yeah.
It's amazing how many respiratory therapists smoke. And you would think of all the patients that you see that have lung cancer, their COPD, they're dying for a breath of air. Every single breath they take in their life is so much effort, and they're just tired, and you see that, and then you go outside and smoke a cigarette. I don't get that. So I understand, though, that cigarette smoking is such an addiction. Supposedly, it's easier to quit heroin and cocaine than it is to quit cigarette smoking. So it's a horrible addiction, and I really feel for the people that are addicted. But the smell of a cigarette, oh my gosh, do I get sick. So I'm glad for it.
Pretty horrible.
It is. So tell me what's floating around in this alveolus. Macrophage, good. I love these electron microscope pictures. What are these granular looking cells on the side of the alveolus? Type 2 cells, and what do they do? Secrete surfactant. Good job. All right, so alveoli become damaged with different diseases. And this is a real complicated looking cell that goes through all the inflammation and what happens when an alveolus gets damaged. And so it can happen with a massive infection in the body. It can happen like with an automobile trauma. When there's a lot of trauma to the body, it ends up affecting the alveoli because there's inflammation in the body and it tends to spread everywhere. And that's how patients like that end up short of breath. They end up with usually like a non-rebreather mask, or they end up intubated on a ventilator, not because they're having problems with their lungs, but because of the trauma, the lungs end up getting damaged. So you end up having all kinds of patients that end up on a ventilator. So the problem that happens is when you have fluid that enters the alveoli, it makes it really hard for oxygen to get over here to where the blood cells are. So if you can't oxygenate somebody, you can imagine that we're really challenged. So as a respiratory therapist, that's your job. So you recommend therapy. Usually a respiratory therapist works under a pulmonologist or a physician. And your job as a therapist, though, is not just to carry out orders, but you have to make sure what's ordered is safe. And then your other job is to recommend therapy. So if somebody is on a non-rebreather and they're not saturating, you would call the physician and say, we have, Mr. Jones is on a non-rebreather mask, his respiratory rate's 30 times a minute, and his O2 saturation is really low. I'd like to recommend that we put him on positive pressure therapy, CPAP or BiPAP you learn about. So that's your goal, is to recommend therapy. Once you're working in the field for a while and the physicians know you, then you pretty much know what they want. So rather than making a phone call each and every time, they give you protocols to follow. Well, if the saturation's low, you know what I want you to do, and I'll have you carry out the orders. But a respiratory therapist works under the direction of a physician. Okay, next we talk about interstitial spaces. There's connective tissue in the lungs, which is between the alveolar epithelium and the capillary endothelium. So the lining of the capillary, and then you've got the alveolar epithelium. So in between that, there's stuff, and that stuff is connective tissue. Well, fluid can accumulate in the interstitial spaces of the lungs with certain diseases, and it tells you heart failure and kidney failure. So the way that the lungs and the heart are related, when the heart isn't functioning well, the ventricle contracts, and it's supposed to squeeze the blood out of the heart and send it into the aorta and the rest of the body. But if the heart's not working really well, when it contracts to squeeze blood out, not a lot of blood goes out. So what happens is blood backs up from the left ventricle into the left atrium. From the left atrium, it starts to back up. Now it's into the pulmonary veins. It backs over into the lungs, into the pulmonary capillaries. There's a lot of blood in those capillaries because it just can't go forward, and it can't get out of the left side of the heart. And what happens is when you have a lot of blood in that capillaries, it's a lot of pressure, and it starts pushing fluid out of the capillaries into these interstitial spaces. Well, when that happens, it becomes really hard to breathe. So instead of breathing in and out nice and easy, now all of a sudden you have to really work to get air in and out of lungs that are full of fluid. So that's the connection between heart failure and having a hard time breathing, is that fluid will tend to accumulate in those interstitial spaces. With kidney failure, when the kidneys are not making urine, fluid tends to back up into the vessels, into the vascular system, same thing happens. The capillaries going through the lungs are so engorged with fluid, the fluid ends up leaving the capillary, going into the interstitial space of the lungs, and now the person comes to the ER, not because don't have a urine output, but because they're having such a hard time breathing. So the fluid just backed up and is in the interstitial spaces of the lungs. And then it gets worse, where fluid can actually, blood cells can actually get into the interstitial spaces, into the alveoli, and then the patient starts coughing up this frothy pink secretions, and it's coming from the capillaries into the alveoli and coming up the conducting airways, and you see them coughing up all this frothy pink mucus. What is the point of this? An alveolar wall through which oxygen and carbon dioxide can diffuse. Oh, okay, so we've got the alveolus, we've got our alveolar epithelium, and then here we have our capillary and the capillary endothelium. And it's just showing you how there's very little space between the two that makes it easy for oxygen to get into the red blood cell and for carbon dioxide to leave. And here you see it's a lot thicker, so you can tell that this is not where the oxygen will cross over, but only where it's really thin. All right, let's talk about the mucosa of the respiratory tract. The mucosa is lined with cells, and the cells have that fancy name I was mentioning earlier, pseudostratified ciliated columnar epithelium. So when you break the name apart, you can understand what the epithelium looks like. Pseudo-stratified means fake layers. So the way that the nuclei line up in layers, it looks like there's more than one layer, but there isn't. So it's called pseudo-stratified or fake layers. Ciliated because there are cilia on each of the epithelial cells, and cilia are microscopic hairs, and they beat to move mucus toward the larynx. And they beat constantly. I have more information about that. Columnar tells you that they're tall cells. Epithelium describes the type of cell. We want a picture. All right, so this is a good picture showing you the pseudo-stratified, ciliated, columnar epithelium. So you see these layers of nuclei and make it look like there's different layers of cells, but it's really one layer. There's cilia on it. The cells are tall or columnar. So when the cilia are beating or moving, they're moving this layer of mucus. There's it's called a mucus blanket that always lines all of the mucosa. And the mucus blanket doesn't just lay there, it's constantly moving. It produces, you normally produce about 100 mLs of mucus a day, but you don't notice it because you just swallow involuntarily and you swallow the mucus, which is fine. There's nothing wrong with swallowing mucus, by the way. So the mucus blanket will produce about 100 mLs of mucus per day. The mucus is sticky and traps foreign particles, dust, and bacteria. So the mucus is sticky. It traps foreign particles, dust, bacteria. Cilia are constantly moving 15 times per second. So they'll move forward and recoil back, move forward, recoil back, 15 times in 1 second. So when you're learning about different drugs, well, first you study the effects of tobacco smoke. Tobacco reduces ciliary movement, and it also destroys the cilia, those little hairs. And then when you're talking about anesthetic gases, it causes paralysis of the cilia. So after surgery, there's mucus accumulation, so we always encourage patients to take deep breaths and cough so they don't end up with a pneumonia from infected mucus in their lungs. So that's the application clinically.
This is what gets dried out if it's not humidity.
Perfect, yes. Yeah, and not having enough humidity in the respiratory tract will dry out the mucus blanket, and then it won't move forward and be cleared naturally. So we're always concerned about providing humidity when we're providing air for patients to breathe in. Next thing on your list is goblet cells. These are located between the epithelial cells. So here's a goblet cell. The goblet cells produce mucus. Oh, pointed to a serous cell and not a goblet cell. Mast cells are next on your list. Let's look for the mast cells in the picture. None here. None there. Okay, here's some mast cells. So you see the cilia, and in between the epithelial cells, there's these round circular things, and those are mast cells. And what's contained in the mast cells are histamine and other vasoactive substances. So when a mast cell breaks open, and you can see some of them with openings in them, when the mast cell breaks open, it releases histamine and causes a chain reaction for the immune system to kick in and destroy whatever is in the airway. And for some, it's not something that needs to be destroyed. So if you breathe in, I don't know, cut grass, and that cut grass, you smell it, it ends up in your airways, and it causes the mast cells to release histamine, and that starts the pathway of inflammation, because the body wants to get rid of this substance that's in your airway. So there's mast cells in airway, there's mast cells in your stomach. So same thing if you eat food. It's supposed to protect your body, but sometimes you'll eat like a strawberry, and you notice your nose will start running and you'll start sneezing, because it sets up that inflammatory pathway, because the mast cell broke open and released histamine, and now it leads to the sneezing, extra mucus gets produced, inflammation occurs. Next on your list is lamina propria. This is connective tissue below the epithelium. And connective tissue is just supporting tissue. Below that is submucosal glands. Pardon me. The submucosal glands are the major source of secretions in healthy lungs. All right, well, so we'll look for a submucosal gland. We don't need to come back to this slide. The cartilage, the adventitia, again, it's just supporting tissue around the airways. So across view, so we're talking about the mucosa of the respiratory tract. So take a look. So here's the mucosa. The supporting structure would be the lamina propria, the connective tissue. You can see the submucosal glands below the mucosa, and that secretes mucus into the airway. Can you see the submucosal gland? So it's below the epithelial layer, and these glands, their whole purpose in life is just to produce mucus and then secrete it into the airway. And then the cilia have something to move around. You see the submucosal gland in this picture. So you look below the epithelium, below the lamina propria, and then you see the submucosal gland. So these glands really proliferate in cigarette smokers, chronic bronchitis, when there's a lot of mucus being produced. Usually that's one way that chronic bronchitis is diagnosed, is the physician will ask the patient, well, how often do you produce mucus? And if it's 2 or 3 months out of the year, that's considered chronic bronchitis. So what happens is the airway just kind of remodels itself and starts having more mucus glands. So tons of mucus are being produced, and it's in response to usually cigarette smoke or something that's being inhaled that's irritating the lungs. It shows the cilia beating. So you see it moves it forward, and then it recoils, and then stands up, and then pushes the mucus forward. Mucus has a watery layer and then a thicker layer on top, or a gel layer. All right, just a couple more slides and then we're done. Where's the visceral pleura and the parietal pleura? Oh, they're coming up in a couple pages. Okay. When you're referring to the thorax, you refer to landmarks, and landmarks are just imaginary lines that we look for. So, mid-sternal line, or no, the first one, I'm sorry, is mid-clavicular line. Can you tell where a mid-clavicular line would be? If somebody tells you, put your stethoscope on the right mid-clavicular line. Is it pretty obvious? Middle of the clavicle on the right side. What about mid-sternal line? Center of the sternum, middle of the sternum. Mid-axillary, over here. Left and right scapular line in the back, in the middle of the scapula. Mid-spinal, middle of the spine. All right, so those are easy. And this shows the pictures. And then the mediastinum is located between the sternum and the vertebrae and between the lungs. That's the location of the mediastinum. It's between the sternum and vertebrae. Sternum in the front, vertebrae in the back, and then between the lungs on each side. So it forms this big cavity, and within this big cavity, or within the mediastinum, you have the heart, the great vessels. Do you know what the great vessels are? Aorta. Pulmonary artery. Superior and inferior vena cava. And then there's the hilum. The hilum is an opening for the main stem bronchi. For the pulmonary vessels. The lymphatics and the nerves. So bronchi, blood vessels, lymphatics, and nerves. So if I tell you, find the hilum in this picture, would you say it's up here? Is this the hilum? No? What else? I can only think of A or B. How about here? Where you've got your blood vessels going to the lungs? Do you see the main stem bronchi in there somewhere?
It's behind part.
Okay. So we can't really see the main stem bronchi. We can see the trachea, so we know it's going to branch and go over the heart, so we can't see it, but we've got main stem bronchi here. So yeah, this is the hilum, where the main stem bronchi go across to the lungs. It's where everything leaves the mediastinum. Okay, and then last we'll talk about the pleura. Okay, let's look at a picture first, and then I'll give you some things to write down. There is something thin, it looks like saran wrap, that lines the rib cage, and something thin like saran wrap that lines the lungs. And they're called pleura. And usually the two pleura are next to each other. They're only separated by a very thin layer of fluid. All right, so back up to write some notes. So the parietal pleura is a thin layer of tissue that covers the inner surface of the chest wall. Covers the inner surface of the chest wall. And the visceral pleura is a thin layer of tissue that covers the lungs. Right, in between the visceral pleura and the parietal pleura, we call that the pleural space. But it's really a misnomer because there is no space between the visceral pleura and the parietal pleura. They're next to each other, and there's only a thin layer of fluid. So let me explain pleural space. It's actually a potential space. What can you write down? That's pretty much what I have on the notes. There is no space between the pleura and a healthy person. There is no space between the pleura and a healthy person. In heart failure, fluid accumulates in the pleural space. In heart failure, fluid accumulates in the pleural space. So when fluid accumulates in the pleural space, it's called a pleural effusion. And when you're listening to breath sounds over this area, like if there's fluid accumulated here and you're listening to breath sounds, instead of hearing normal breath sounds, you hear like this hollow sound, like you're listening through this big, large tube. And so instead of it being all the alveoli getting air, you just hear like almost like wind blowing, like. So that's listening to breath sounds through fluid. That's what it'll sound like. When you look at a chest x-ray, instead of seeing sharp angles where the lungs meet the rib cage, you will see a blunted angle. So even if you're not looking at the x-ray, if you're just reading an x-ray report on your patient, it'll say blunted costophrenic angles, or it'll say costophrenic angles are sharp. So if it says blunted costophrenic angles, it's talking about the angle where the lungs meet the rib cage. It forms like an angle right here. That's the costophrenic angle. Do you know how to spell it? C-O-S-T-O. Phrenic is P-H-R-E-N-I-C. Costophrenic angle. And that's where the lungs meet the rib cage. Normally, the angle is sharp. So you can see the angle really well with healthy lung tissue. But when fluid accumulates in the pleural space, now it's going to look like, instead of a sharp angle showing up on the x-ray, you'll just see a line. And that's because lung tissue collapsed away because there's fluid in that area. So when there's fluid there, you say costophrenic angle is blunted. B-L-U-N-T-E-D, blunted. All right, so just a couple things to point out. So when you're looking at this picture, can you see this thin layer of tissue right next to the rib cage? Looks like it was cut away to show the lungs. What is this thin layer of tissue called? That's the parietal pleura. What is this angle called where lungs meet the rib cage? Costophrenic angle. I think that was it. And then sometimes when you have stomach irritation, it causes hiccups. And that's because the stomach is right underneath this diaphragm. And an irritated stomach can cause like innervation of the diaphragm, and the diaphragm contracts very quickly and gives you a hiccup. No, that's not a test question. All right, so we're finished for the day, even though it's not 12 o'clock.
I have a question. The flora, the partial flora and physical flora, that is connected, right? It's not two separate things, like...
Two separate layers.
It's two separate layers, but there's no like... And the space in between it, but two separate layers?
It says it's the same membrane, it just folds.
Yeah.
Oh, okay. So textbook says that it folds and becomes
Yeah,
one
Yeah.
at some point?
It's parietal, but then it just folds to be visceral.
Yeah, that was wondering.
But it's continuous. That's what it says.
Okay. There you go.
Yeah, that's what I was thinking. I was really sure that I read it properly.
All right, any other questions?
Are we gonna see the next slides next class?
The next slides, yes. So we'll finish the handout next Tuesday.